the next session is an interview, the interviewee is Dr. Laila Tata, who's one of our new the members of our new scientific committee. And Laila's an associate professor of epidemiology, and she leads a perinatal epidemiology research group at the University of Nottingham. And she's particularly interested in the epidemiology of pregnancy and maternal child health. And she works a lot in constructing and using large databases. And she, in respect to psychiatry, she's particularly interested in the consequences to women and their children of chronic conditions and related prescribed medication. Particular interest in depression and anxiety, but also in severe mental illness such as postpartum psychosis. So, and Laila's going to be interviewed by one of our scholars, Jessica Radley, and the questions that she's going to be asking are questions that were formulated by the scholars at their pre-meeting where they about a couple of weeks ago. So I think without any further ado, we should start.
Great. So yes, hi Laila, it's really nice to meet you, even though it's online. And I've got a bunch of questions here about you and your career and your viewpoints. So the first question I've got is, what was your journey into research on epidemiology and mental health and on mental health?
Gosh, journey. I remember you said 20 minutes, so don't talk for too long. Yes, my journey into epidemiology really was, I did a degree in physiology in Canada at McGill, and then I was interested in studying international health. So I didn't really know what epidemiology was. I did an internship overseas in Thailand, which was actually in tobacco control. And I really enjoyed it. And one of the things I was tasked to do is develop fact sheets about tobacco control and tobacco use in Thailand. So I spent a lot of time, that was my introduction, I think, to looking at what evidence was out there, how many women in Thailand smoke, for example, is something that we were looking at, and I was finding lots of different answers, and I think that really sparked my interest in knowing, well, what is the actual answer, what is the reality here, so yeah, so that sparked my interest in research. And then I was told about the London School of Hygiene and Tropical Medicine, and I was told about that by a family friend and went to do a degree in epidemiology there, and really enjoyed that. And that really captured learning about population health, or what's the distribution and the determinants of different health states and diseases in populations. So that's where I landed with epidemiology, really.
Yeah, I've heard that the London School of Hygiene and Tropical Medicine is one of the best places to go for things like learning about epidemiology, statistics, things like that. And then what led your journey into more mental health research away from physiology, more physical health?
Right, I think that probably with the group here today, I probably study the least mental health research, but I think I have a personal interest in it, having experienced different mental health problems in my family. But the interest in terms of research was really sparked through my PhD, which looked at the safety of asthma medications in pregnancy. So when you're looking at drug safety in pregnancy, you have a big barrier, of course, to be able to do clinical drug trials. So using epidemiology and using big data, you need hundreds of thousands of people to study risks of medications in pregnancy, because pregnancy is risky. So adverse outcomes like congenital anomalies happen in general. So how do you determine which ones might be related to the risk of taking a medication? So after looking at asthma medications, I realized through that research that the data that I was using, which are general practice data from the UK and hospital data, was really, really valuable to be able to look at drug exposures in pregnancy over hundreds of thousands of women across the country, looking at their prescriptions and then being able to have linked records to their pregnancy outcomes, including their children's health outcomes. So I then looked at risks of antidepressants, and at the time, that now there's a huge amount of research looking at antidepressants and their risks in pregnancy. And I guess that I was doing this about 10 years ago, looking at big data, and at that time there weren't a lot of very, very large studies looking at risks of congenital anomalies, for example, but in particular comparing the risks and benefits of taking antidepressants versus not taking antidepressants, knowing that there are huge risks of depression, having depression itself, as well on some pregnancy outcomes. So it was really looking at those risks and benefits, and now we have a huge number of studies, and we're still there's still a lot of controversy over the risks and benefits of taking antidepressants during pregnancy now. So
yeah, that's really interesting. In my work with parents with psychosis, so yeah, often also thinking about the risks and benefits for both the parent and the child as well. So it's complicated, and that kind of leads me on to this next question, which is, how can we use what we learn from epidemiology research to inform interventions?
To inform interventions, I think what we need to understand from informing interventions is being able, I think in terms of this area, is there's no one size fits all. And I think we probably need to learn a lot more about the different, you could say the different phenotypes, genotypes and phenotypes rather, of mental health conditions, and how they act in different groups, how they recur, why they may not recur, and really try and think of tailoring interventions first, and realizing probably at the moment where we are using a lot of interventions that might be for depression in general, without recognizing that actually that the depression is probably a group of very different conditions and different etiologies and different groups of people. So thinking about how we maybe take a step back and think of that interventions really need to be thought through more and tailored more to individuals. And I think epidemiology helps with that in terms of identifying what are common risk factors or similar risk factors between people, but also what are the differences, and then delving a lot deeper, without epidemiology, and looking for the reasons why, what are the answers why, which is something that epidemiology can't always answer.
Yeah, that's really interesting. And it's interesting about not thinking about one size fits all with interventions, but maybe interventions that are more tailored or even modular. So thinking about maybe it's an intervention for depression, but actually which of the modules of this intervention make most sense for each individual person. Yeah. So as Michael Owen said, you also work a lot with large data sets and linkages. So I was wondering what you've found to be the benefits and the challenges of using large data sets and linkages in research.
The benefits and the challenges. Well, I think they're huge benefits, and I think that over the past, since I've started working with these databases, they've changed absolutely enormously. One of the benefits is the ability to link across different data sources increasingly. So countries like Sweden and Norway, you kind of get an identity number from birth, and you can link across different administrative systems. So that enables a big richness of data on very large numbers of people. So in the UK, it's a bit different, but we're more and more getting towards richer linkages that can look at people over time. So the numbers of people that you can look at are a huge advantage, and again that can help us distinguish between chance findings, which we get in a huge amount of research just purely because we're looking at very few people, and the data that are on numbers of people can be more representative of the population, and so give us a more realistic picture at a population level of what is happening in terms of numbers, and also being able to look over time. So now with linkages, we can look over people's lifetimes. So in countries like Norway and Sweden, they really truly have the ability to look at a lifetime. Here we're a bit more patchy, but the longer we have these electronic data sources, the more we're able to look at the cohort and changes over people's lives. So I think all of those things are extremely valuable. The disadvantages, there are numerous. First of all, the data that we have available clinically are clinical data. So people have to interact with healthcare services in order to be captured by the data. And so that involves, on the flip side, a huge amount of potential factors that might make it not representative of the population. You need to be somebody who goes to your GP or is more likely to interact with health services. And we know that there are huge inequalities in populations within cities, within the country, internationally, that affect people's ability to interact with health services. And so that also means that there's lots of biases in the data, and those things really need to be recognized, and they're quite hard to tease out. And that's where, combining, ensuring you have patient and public involvement, which was discussed a lot in the previous session, and both in terms of designing those big data research studies in the first place, and also in interpreting them, I think is really important, and recognizing these biases before you start, and also whilst you're doing the analyses.
Yeah, that's a really fair answer. Yeah, and so interesting when you look at the studies with Norway and Sweden, you just can see just how much data there is on everyone in the population. It is really interesting studies, but then you have to appreciate that that's very specific to, say, people who live in Norway and Sweden, and actually, what's it like that they have a lot of healthcare and stuff. So the findings might not apply to people in America. So it's quite interesting to think about that, but also it's specific to Nordic countries. That's great. So my next question is, we know you often work with researchers overseas. How did you go about building international collaborations?
I think a lot of them just sort of fell into place. I'm trying to think. The main collaborations that I've developed have been through wanting to ask similar questions in different populations. So my collaborations overseas have mainly been using data sources that are all already collected to answer questions, rather than designing studies from scratch. So using administrative data to answer similar questions. So in Sweden, we've looked at venous thromboembolism, so the risk of blood clots in pregnancy, and looked at the same questions using Swedish data and English data. And as you said, that our populations are quite different. So their obesity rates in pregnancy are very low, and overweight in comparison, I should say, to England. Their C-section rates are a bit lower. However, if you look at C-section and obesity, they confer similar risks to having a blood clot during pregnancy. So looking at comparing and contrasting those. And it really, in terms of how I've established those collaborations, it has been through in contacting researchers and saying, oh, we're very interested in this area, and we know that you use similar data, and would you be interested in collaborating? So just really just reaching out, showing interest in other people's research.
Yeah, that's fantastic. So, yeah, just a bit of networking. And then I've got a question that's kind of interesting for, I think, everyone here. It's so we know that mental health research is underfunded compared to other areas of research. We also know that mental health awareness among the public is increasing. So what are your views towards how we persuade the general public and policymakers of the need for mental health research? Quite a broad question.
Yes, that's a big question. I think trying to, even though we need a badge of mental health research, I think trying to make the population realize that there isn't mental health and physical health, that there's so much interconnectedness, ensuring that mental health is a part of other research. So research in cancer and diabetes, integrating mental health into that, which it already is being done hugely now. But thinking about the fact that I have a friend who has psychosis, who prefers to say she has a brain disease rather than saying she has a mental health illness. So recognizing, getting the population to realize that mental health conditions is related not just to your brain, but we are a collection of organs, really, and that it should be viewed on an equal level, which I think it still isn't by the population, and that I guess is also relates to decreasing stigma in the population. So I think that the group here are much more aware, recognizing that we are much more aware than many people about how much mental health affects everybody, and that there are still big sectors of the population, I should say communities, where there's a huge amount of stigma, for example. So depression around pregnancy and postpartum, and I was looking just the other day, and there's a huge number of studies now that are looking in countries all over the world at postpartum depression. And postpartum depression not so long ago was recognized much more as a Western problem, and increasingly the number of studies you do across the world, you find a very similar proportion of women who suffer from postpartum depression. So I think the more you look at different groups of people, and we're always going to find differences, but the more you discover those similarities and similar experiences and communicate that to the population, I think the more people will realize that this is something we need to recognize and accept, that is affecting all communities, just in the same way as people are thinking about that about cancers.
Yeah. And like you said, with stigma, I mean, there is a particular stigma with words relating to mental health, like psychosis, for example, that do carry a lot of weight behind them as labels. So it's important to recognize that. Yeah. So we've got 2 minutes left, and I've got one final question, and that is, thinking back to yourself as a PhD student, what advice would you give with what you've learned, what you know now?
Keep going, it will finish. When you say what advice to a PhD student, it depends on what stage of the PhD you're in. There's that kind of excitement, and it's quite a journey, isn't it? You have to love research, I think, really. My advice would be you really need to have this underlying interest in answering questions and finding answers, and because the field will change rapidly as you do research, and you'll feel like you're overtaken in some areas, but there are venues and avenues, I should say, for everybody, and there's so many questions to answer. So I would say that the biggest thing is you have to make sure you have that love for doing research, and you also have to realize that your PhD is probably going to be the best time of your research life, in terms of the fact that you have this wonderful protected time to do your project. And the more you move forward with research, you get involved in other collaborations, and you do lots of different projects, which is absolutely brilliant. It's brilliant to work with all sorts of people, but you don't get that time to do your own project quite as much. So I guess that's not a piece of advice for the future, but it's just to keep in mind that value that time, and I think then if you see that joy in each individual project, then you'll enjoy the further collaborations.
Great. Yeah, I think that's a really good piece of like universal advice for any PhD student in any field. So thank you so much for answering all of our questions.
Thank you.
Thank you very much.